Order. A quorum is present. Before we begin, I would like to ask unanimous consent for members of the Washington delegation to participate in today's hearing, should they be able to attend. Without objection, so ordered. Without objection, the chair is authorized to declare a recess at any time. Before we proceed, I would like to go over a few housekeeping items for our remote hearing. First, if you are experiencing connectivity issues, please make sure you or your staff contact our designated technical support so those issues can be resolved immediately. Members participating remotely must continue to use the video function for the duration of their participation in the hearing unless they experience connectivity issues or other technical problems that render the member unable to fully participate on camera. It is the committee and the subcommittee policy that members will remain muted when not recognized, just like turning your microphone on and off during an in-person hearing. This is out of courtesy to all members on the committee, and so that background noise does not interfere with another member who is recognized to speak. When you are recognized, you will need to unmute your microphone and pause for a couple of seconds before speaking so that we will be able to hear everything you say. In order to ensure everything members say is captured on the live stream of this hearing, I ask that members pause for 2 to 3 seconds before beginning to speak. If you wish to have a document inserted into the record, please ask for unanimous consent and have your staff email the document to veteranaffairs.hearings@mail.house.gov. It will be uploaded to the committee document repository. Without objection, members will be recognized in order of subcommittee seniority for questioning witnesses today. This will make it easier for me to ensure all members participating have an opportunity to be recognized. Does any member have any questions about the procedures for this hearing? Hearing none, we shall proceed. I now recognize myself for an opening statement. Thank you for joining us this afternoon for the first hearing of the Subcommittee on Technology Modernization in the 117th Congress. I want to acknowledge the work done by the subcommittee in the 116th Congress and to thank former Chair Susie Lee and former Ranking Member Jim Banks, fellow Hoosier, for their exceptional leadership. I'm honored to assume the gavel and am grateful to my colleagues on the Veteran Affairs Committee for entrusting me with the responsibility. I also want to acknowledge Representative Matt Rosendale and congratulate him for being elected ranking member of this subcommittee. Mr. Ranking Member, I look forward to working with you in this Congress and hope that we can continue the level of bipartisan cooperation that the Veteran Affairs Committee has historically been known for. Given the magnitude and the status of the Electronic Health Record Modernization, or EHRM project, it is only fitting that this is the subject of our first hearing. This subcommittee has and will continue to be focused on ensuring that the program produces what has been promised, a high quality system of health records that support and enable clinicians and ensure that the VA staff are able to deliver a seamless healthcare experience for veterans. Since the subcommittee last met on this topic in September of 2020, VA deployed the Cerner Millennium product at its first initial operating capability, or IOC, site at Mann's Grandstaff VA Medical Center in Spokane, Washington. I want to thank frontline personnel at Mann's Grandstaff for their dedication to our nation's veterans and their willingness to be the first facility to undergo this monumental change, particularly during a pandemic. It's never easy going first. It shows that the VA staff are ready and willing to facilitate VA's IT modernization efforts. It is clear that a lot of effort went into this implementation, and no one doubts the dedication of the program or contractor staff involved. However, there is still a lot of work to be done. Reports out of Spokane seem to indicate that the project could benefit from some major fine-tuning before it is deployed to another VA facilities. On January 25th and 26th, Dr. Richard Stone, the Acting Undersecretary for Health and Dr. Cameron Matthews, Undersecretary for Health for Clinical Services, visited MAN's grant staff to investigate issues with the deployment. As I understand it, frontline staff and facility leadership had major concerns about prolonged loss of productivity, staff morale, and insufficient management data coming from the system. I'm also concerned to hear reports of patient safety issues. I hope to hear more today about their observations, the issues raised by frontline staff, and the status of the resolving of these issues. We've learned that VA stood up a number of Tiger teams in response to the issues identified by Dr. Stone and Dr. Matthews. I still have many questions about the work the Tiger teams were tasked with and expected outputs from those teams. On March 17th, 2021, the VA Secretary notified Congress that he was directing VA to conduct a strategic review of the Ehrm program. We need a better understanding of what this strategic review entails, the possible outcomes VA anticipates, and this means for long-term timeline and budget of the project. I would also like a better understanding of the structure of the review process, who the players are, what topics are being evaluated, and how VA intends to ensure that frontline and veteran voices are being incorporated. Dr. Stone has raised concerns about prolonged loss in productivity at MAN grant staff. This has major impacts on wait times and veterans' access to care, as well as their health and well-being. While some level of productivity loss is to be expected following a major IT transformation, this subcommittee needs a better understanding of the current state of productivity and how VA and Cerner plan to address it moving forward. Specifically, I would like to focus on the workflows. As VA undertook this monumental task of modernizing its EHR, it also committed to standardizing clinical workflows across the enterprise, something intended to put to rest the concept of if you've seen one VA, you've seen one VA. While this laudable goal, these new standardized workflows appear to be a sticking point in VA's progress. Dr. Stone himself has indicated that the new workflows may have been over-engineered and may not have been taken enough input from frontline providers into consideration. I hope to hear today how the standardized workflows were evaluated by the Tiger teams, whether they are included in the strategic review, and how any potential over-engineering or shortfalls are going to be addressed by the VA. It has been over a year since the subcommittee first heard concerns about the training provided to both end users and super users, and training remains one of the biggest issues facing this program. I hope to hear our witnesses' evaluation of the VA's training program, if it adequately prepared providers and support personnel for the transition, and how the VA plans to improve this crucial component of the project. The subcommittee has been consistent in its message that VA needs to get the program right, rather than adhere to any artificial deadlines. While we understand that this delay is part of getting it right, at some point we can't accept continued delay without a complete explanation from the VA on what the problems and solutions are. I wholeheartedly support the Secretary's strategic review. However, given the issue being raised by frontline staff, and this being the second pause necessitated by concerns over the program, I have my own concerns about the state of the long-term plan. I reiterate this subcommittee's previous calls for complete transparency and accountability. We owe it not only to the veterans who have earned these benefits, but to the taxpayers who are funding this program. I would also add that I was pleased to be able to visit the Adam Benjamin Jr. VA Outpatient Clinic in Northwest Indiana last week to see firsthand their processes and operations to assist veterans with their pressing needs. As we move forward, let us not forget the veterans throughout our nation who are looking for more ease and assistance with obtaining the health care and services they so rightly deserve. I thank all the witnesses for appearing today and for your work on this incredibly important project, and I look forward to hearing your testimony. I would now like to recognize my colleague, Ranking Member Rosendale, to deliver any opening remarks he may have. Mr. Rosendale?
Thank you, Mr. Chair. And I really have enjoyed getting to know you over the last several weeks, and I absolutely look forward to working with you as we move forward in this subcommittee. One of the things I appreciate as a new member of Congress is how people from different parts of the country and walks of life come together to try and solve the problems that we are facing. I want to thank our witnesses from the VA and from Cerner for joining us to talk about the electronic health record modernization program at this critical time. The first thing I did when I was selected for this role was to ask staff to compile the key information of the program. It was startling. It is no secret that the most enterprise technology projects fail. Unfortunately, the bigger they are, the harder they can fall. As the client, scale and complexity are never your friend. This project has the budget of a small country. I think it's very important that we stay focused on our objectives and keep an open mind as to technology solutions, as the client developing tunnel vision rarely ends well. When I took the situation, here's what I say. The VA has an older electronic health record that's falling behind, but is still very usable. The Cerner EHR cannot just be newer, it has to be better. Our veterans deserve the highest quality health care. The test environment for this system leaves a lot to be desired, and it's unacceptable to be risking medical errors while bugs get worked out in a live environment. I understand this is only the latest attempt by the VA and Department of Defense to create a common lifetime medical record. We have to be clear about exactly what that means. If we are only talking about pushing records over the fence when a service member becomes a veteran, the industry has come a long way over the past decade. No one should ever have to lug around a stack of paper medical records, but that is not the monumental technology problem that it used to be. But the idea that the VA and DoD need the same company's software to exchange medical records is frankly ridiculous. However, the compelling reason for the VA and the military health system to both run the Cerner EHR is if they integrate operations in a meaningful way in the future. That is the only way this project ever produces any savings. I need to hear a whole lot more about that. But we are where we are. Congress has appropriated $6 billion already. VA is requesting another $2.7 billion for next year. The electronic health record modernization budget is now over half the size of the entire IT budget. The EHR is a big, important system, but is only one of nearly 1,000 VA IT systems. We should not lose sight of that. Secretary McDonough and our witnesses have acknowledged that all is still not well. I commend them for their honesty. The strategic review is clearly warranted. We had an initial presentation about it last week, and I intend to do everything that I can to make sure this review gets to the root causes of the problems. That begins with defining the areas that need to be reviewed. We cannot just cherry pick the areas that are actually functioning properly. It seems unnecessary for the review to study the Ehrm program's management again. VA already hired the Institute for Defense Analysis to do that for the better part of last year. I'm sure there are plenty of management consultants who would love to sell the government those same recommendations, but I hope our witnesses will go ahead and implement the recommendations from IDA. I think most of the time in the strategic review should be spent re-examining the scope of the project and making sure the contract is delivering effective solutions for VA's actual needs in an accountable way. It's not too late to shore up that effort. Anything else would be a disservice to every veteran who relies on the VA and every taxpayer in this country. Attempting to spend our way out of this hole is the worst possible answer. Thank you all again for participating again. And thank you, Mr. Chairman, and I yield back.
Mr. Chairman, you're muted.
Thank you, Mr. Rosendale. At this time, I would like to recognize my colleague, Mr. Boss, ranking member of the Veterans Affairs Committee, to deliver any opening remarks he may have. Mr. Boss, you're muted. I'm sorry. Yeah, it's contagious. We're all trying to be too polite.
I have to get my grandkids to turn those things on. Mr. Chairman, I want to say thank you, and I appreciate the leadership of this subcommittee and Mr. Rosendale's willingness to serve as ranking member. You know, it is one of the hardest jobs on the committee, but both of you can make a big difference. You know, the electronic health record modernization program is too important to get it wrong. We need to get it done right the first time, even if it means delaying it. I'm glad the VA heeded our call and is conducting a strategic review. The Secretary is looking at the situation with fresh eyes, exactly as he should. The strategic review is an opportunity to get on the right track. It may be the last opportunity to make meaningful changes. As VA and Cerner begin to review, it is vital that a few things happen. First, the review cannot just be about management and organization. It also has to fix the problems in the EHR. That means staying focused on Spokane until the bugs are worked out. The Spokane employees are smart and committed. They step up, volunteered to be the first medical center to implement Cerner. They are doing the best they can, but they're dealing with a system that has made their jobs harder, not easier. We can't leave them high and dry. Second, it would be a mistake for VA to deploy Cerner at any other site until the strategic review is complete. Complete means more than just identifying recommendations. The recommendations actually need to be implemented. The system has to improve, and the VA and Cerner have to agree on benchmarks for what improvements look like. Employees need to have input into these benchmarks. Then Cerner has to demonstrate that the benchmarks are met before VA starts implementing the system in any other medical center. Lastly, the VA needs to rethink its cost estimates and spend plan, and we need to pump the brakes on spending until that happens. We got the administration's budget request last Friday. It includes $2.7 billion for electronic health records modernization. If approved by Congress, Congress will have to appropriate over $8.7 billion to the program. That is over half of the total cost of the entire project. Meanwhile, the VA has barely completed one facility. There are at least 7 years and another 169 facilities to go. That does not make any sense. This spend rate simply cannot hold. I hope the VA will carefully consider each of these areas during the strategic review. I look forward to the final report. And thank you, Mr. Chairman, for having this. Thank you all the witnesses for being here. And with that, I yield back.
Thank you, Mr. Borst. With that, Chairman Takano, I'd like to offer you, would you like any opening remarks?
No, Chairman Mervan, I don't have any opening remarks to make. And I thank you and the witnesses for being here and holding this hearing.
Thank you, sir. I will now introduce the witnesses on our first panel. Dr. Carolyn Clancy, the Acting Deputy Secretary of the Department of Veteran Affairs. Dr. Clancy is accompanied by Dr. Cameron L. Matthews, Assistant Undersecretary for Health for Clinical Services, Veterans Health Administration. Mr. John Wyndham, Executive Director of the Office of Electronic Health Record Modernization. Dr. Laura Krupa, the Chief Medical Officer of OEHRM. Mr. John Short, the Chief Technology and Integration Officer of OEHRM, and Dr. Robert Fisher, the Director of the Mans Grandstaff VA Medical Center in Spokane, Washington. We will now hear the prepared statements from our panel members. I will remind you to please pause for 2 to 3 seconds before speaking so that the recording will capture all of your words. And please remember to do so when answering the members' questions. Thank you. Your written statements in full will be included in the hearing record without objection. Okay. Dr. Clancy, you are recognized for 5 minutes.
Good afternoon, Chairman Mervan, Ranking Member Rosendale, and distinguished members of the subcommittee. Thank you all for your unwavering support of veterans and their families, what President Biden sees as our country's most sacred obligation. When it comes to fulfilling that obligation, we have a fierce advocate in Secretary McDonough, whose vision for the future of VA focuses on 4 fundamental principles: advocacy, access, outcomes, and excellence. Principles grounded in the Secretary's vision of empowering veterans and ensuring that they are at the center of all that we do. Joining me today, as you just mentioned, Mr. Chairman, is Mr. John Wyndham, Executive Director of OEHRM, Dr. Laura Krupa, the Chief Medical Officer for OEHRM, Mr. John Short, the Chief Technology and Integration Officer for the same office, Dr. Cameron Matthews, Assistant Undersecretary for Health for Clinical Services and VA Functional Champion, and very importantly, Dr. Robert Fisher, Director of the Mann Grandstaff VA Medical Center in Spokane. Let me also acknowledge representatives of veteran service organizations attending today. Our work with VSOs enables us to best serve veterans, families, caregivers, and survivors. I appreciate the opportunity to continue our dialogue on electronic health record modernization, or EHRM, so veterans and all Americans can understand this important system. VA is committed, in partnership with the Department of Defense, to leading American healthcare forward, realizing the full promise of a modern integrated record to cultivate the health and well-being of those we serve. In today's healthcare ecosystem, technology powers transformation and innovation. I admire those exponential advances, and yet I know as a clinician that healthcare is fundamentally about people. As the nation's largest integrated healthcare system, caring for the whole person has long been the basis of what we do at VA. COVID-19 reminded us that every aspect of a person's life is important, and that as a society, we're interconnected and interdependent. Now we see hospital administrators having town halls about childcare for their employees, clinicians asking with fervent interest about a patient's family contacts, housing, method of transportation, and even whether they have enough to eat. All of that is about caring for the whole person. VA will realize the true value of this modern EHR when we implement it in a way that furthers our ability to provide care of the whole person, integrating an individual's journey from service member to veteran through VA direct care and community care from Maine to the Pacific Islands. We intend not only to get this right, but to drive the whole industry forward. And that is why Secretary McDonough announced a top-to-bottom 12-week strategic review of the electronic health record modernization program. We remain committed to the Cerner Millennium Solution, and we're taking swift and decisive action to ensure appropriate management rigor and to position this project for success across the nation. We are so proud of the dedicated employees who are moving this effort forward during the pandemic. And as a high reliability and learning organization, we're listening intently to the experiences of veterans and frontline staff. And I appreciate deeply the comments of both members saluting the leadership of our colleagues in Spokane. The strategic review covers a full range of program areas, including productivity and clinical workflow optimization, a human-centered design effort to understand what veterans want to see from VA's patient portal, and a sandbox environment that will allow employees at future implementation sites to conduct interdisciplinary team-based rehearsals of these workflows in the new EHR solution. We're also committed to ensuring greater transparency with information, progress, and findings. While we've laid a strong foundation, you will see us do more to ensure those internal and external to VA, including you as congressional stakeholders, understand the progress of the program. You'll also see us engage in even more robust collaboration with our DoD partners. We must work together to marshal data across our healthcare systems so that we can diagnose faster, improve access and outcomes, reduce costs, and accelerate research and development to achieve the next generation of innovations in medicine to improve care of the whole person. Implementation of a joint solution across the continuum of care will represent a quantum leap forward in American medicine. VA will lead the way forward on behalf of veterans, their families, caregivers, and survivors. Thank you, and I look forward to your questions.
Thank you, Dr. Clancy. A reminder to my colleagues that members should pause 2 to 3 seconds before speaking so that all of your questions are captured. I will now recognize myself for 5 minutes of questions. For Dr. Clancy, the subcommittee has been very focused on patient record flags, specifically behavioral health and suicide prevention flags. Veteran suicide reduction is very important to me and to the committee continues to hold this as a major focus of our work. There's been a lot of confusion on this topic, so I'd like to get to this as clear as possible. My question is, we've heard that during the cutover from Vista to Cerner at Mann's Grandstaff, the suicide risk flags did not migrate from the Vista to Cerner and had to be manually re-entered. Is this correct?
I'm going to take that for the record unless Dr. Fisher has something to add.
Good morning. Good morning, ma'am. Good morning, everyone. I will say that patient flags have been an evolving issue that slowly but progressively we're solving. And so as we elevate concerns with patient flags and other issues to senior VA and OEHRM senior leaders, we are progressively improving and solving some of those problems.
My next question is, if so, has this issue been corrected to ensure that it won't be repeated at the VA's next go live, presumably in Columbus?
Well, I would say in general that a very important byproduct of this strategic review is that we expect and look forward to our colleagues in Spokane feeling so confident in this system and that the problems they have identified have been resolved, that they can be the forward-leaning ambassadors, if you will. And after any initial deployment, we would be having a review in any case to make sure that if there were problems, we would have them corrected and identified for the next site where it's going to be deployed. A long-winded way of saying yes to your question.
Thank you, Dr. Clancy. To be very specific, if a patient who has received care at a facility that is still on Vista is then treated at Mann's Grandstaff, will all national patient record flags automatically show up in their Millennium record?
Dr. Krupa?
Yes, the 3 national patient safety flags do migrate from Vista into Millennium.
Will staff member have to discover the flag in the joint legacy viewer and transfer the flag to Millennium?
No, the flag will be viewable in Millennium. I think some of the initial issues were people, uh, the fundamental issue in Cerner is that the view that each person has is different depending on their role. So some people who are used to seeing it in a certain place were no longer seeing it the same way. And so we've made adjustments to make sure that everyone knows where those flags are. And we've also added the view of the flags to other staff members who perhaps were not seeing those initially. So we've been, as Dr. Fisher said, we've been evolving that, but the flags were migrated with the data and were viewable for the appropriate roles at the start.
Thank you, Dr. Cooper. And in reverse, if a patient who receives care at Mann's Grandstaff subsequently seeks care at a VISTA facility, will national patient record flags automatically and predominantly display on the VISTA?
Yes.
In the Tiger Team final closure report that the VA provided the committee, the behavioral health team identified that, quote, suicide prevention staff must verify registration information when they get into CPRS and try to place a flag. I'm not sure I understand this issue. Why are staff logging onto CPRS, the legacy system, to place a flag on a patient's record at a facility that is now live with Millennium?
Sir, I would have to take that for the record. I'm not aware of that.
Okay. And the closure report also identifies no ability to see patient flags during registration, conversation, and patient tracking, so doesn't provide prompt warning. The report also indicates that the solution is on hold pending feedback. My question is, does this mean that registration clerks are not able to see if the patient in front of them is at risk for suicide or has history of behavioral issues or violent outbursts?
So that was one of the user role changes that we were talking about in terms of trying to make sure that all the people who wanted to see the flags could see them and knew how to access those flags. So that's some of the work that we're currently doing.
Okay. Thank you very much, Dr. Krupa. I'd now like to recognize Mr. Rosendale. Mr. Rosendale, you are recognized for 5 minutes for your questions.
Thank you, Mr. Chair. I don't see Mr. Wyndham on the screen there. Is he there with us? There he is. Okay. You guys are switching out with Ally, I see, or I. Mr. Wyndham, in our previous hearing, I asked Secretary whether the electronic health record modernization program can still be completed in 2028 for the $16.1 billion. And his answer was yes, flat out, unequivocally. Based on reading the past several years of briefing slides and reports on the program, I hate to say, but I'm skeptical that this could happen. So if we go through the math together, Congress has appropriated about $6 billion to this program since 2018. How much of that has already been spent?
Sir, test on my mic. Can you hear me, sir?
Sure.
Presently, there has been $3.8 billion obligated on this program to the EHR, and approximately $2.6 billion has been spent. I think sometimes there's a misnomer about obligation and expense. As a matter of fact, our expense rate is far slower than our obligation rate because we don't pay the bill, sir, until the work is done. So we feel good about the rate of expense relative to obligation because the work has to be done for us to authorize payment. So I just hopefully I was able to clear that up. So I feel good about the funding profile, sir. You folks have been incredibly gracious in providing us stable funding. And we look forward to the results of the assessment to come back to you with what the assessment reveals with regards to how we need to approach the remaining deployment solution and whether funds need to be moved or reallocated for that work. So we owe you some homework, sir. I think that comes after the homework associated with the strategic assessments.
Well, I'm hoping that a lot of that 2.6 was for the actual hardware and not necessarily for the software and the upgrades on the equipment, because the results and the reports that we're getting as far as the effectiveness of the rest of the program has not been shining, shall we say. If the cost estimate is going to hold, you've already gotten more than 1/3 of the money Congress is going to appropriate, obligated, maybe not actually spent. If we are more than 3 years with 7 years left. The Cerner EHR is up and running at the one site so far, with 169 sites outstanding. One site, 169 sites. Again, when we start looking at these numbers, I admit I went to school before Common Core math, but this is not adding up to me. Okay. Even if each future site goes faster, how can the old cost and schedule possibly be achieved?
Sir, we understand your concern. The efficiencies that are gained through the IOC process, the initial operating capability process, are going to be used in deploying the solution across the enterprise. So there are substantial efficiencies to be gained. Again, I think this assessment is incredibly valuable because it allows us to see where those efficiencies will be gained. It's like the first time you try something, it's hard, and then you get better and better and better. This IOC process is doing what it needs to do. It is that bite of the apple, sir, that allows us to affect the appropriate changes, efficiencies, and assessment values before a full deployment decision that takes us across the enterprise, sir. So we look forward to briefing you on at a greater level of granularity, your staff at a greater level of granularity if you so desire. But we see the timeline over 10 years, and we think it's feasible, sir.
Okay, moving on. Dr. Clancy, I understand Cerner has already implemented a joint health information exchange in the VA nationwide, which is how records are being exchanged with DoD and private doctors through Cerner's Commonwealth Consortium. Is that correct? And how much did that cost?
That is correct, and I believe that we pay for that on an ongoing admin fee basis. Do I have that right, Laura?
I'm not familiar enough. I believe that it's part of our 10-year contract with Cerner. It's part of our fixed price contract that we have with them.
Commonwealth is a nonprofit that set this up some years ago, so we are taking advantage of their very early investments.
Okay, so when someone has an opportunity, if they could include or give me the information on how much that costs, even if it's the
Absolutely.
10-year contract, and make an estimate on how much of that is being dedicated towards Commonwealth. It looks like I've run out of my time there, so I'm gonna yield back to you, Mr. Chair. Respect your time.
Just one brief point, Representative. I would say to you that we will be very, very clear about the costs and the timeline in the final report from the strategic assessment. So I just wanted you to know that.
At this time, I'd like to recognize Chairman Takano for questions for 5 minutes, please.
Thank you, Mr. Chairman. I want to begin my questioning with Dr. Clancy. Dr. Clancy, to say the least, EHRM represents a major undertaking at VA, and I was pleased to hear that progress didn't stop during the pandemic. On the other hand, I'm sure you agree that the go live at Man Grandstaff did not go as smoothly as we had all hoped, and a significant number of issues remain to be resolved. Please explain how you will ensure that the challenges experienced in the first deployment of the EHRM are not experienced at future facilities.
Thank you so much for the question, Chairman Takano. I think that is a major purpose, not the only purpose, but certainly a major important part of this strategic review, as it would be for any multi-site implementation of an electronic record. Things will go wrong. The pandemic was not helpful in terms of implementing a new record because it interfered with some aspects of planned training. And quite honestly, many of our colleagues were infected by COVID and couldn't come into work and so forth. Nonetheless, the team persevered. We will be learning a lot that we expect will be applied to Columbus and future go live sites.
Well, thank you. Thank you for that response. In your testimony, you stated that VA has conducted a deep dive analysis of Cerner's contract deliverables. Could you tell this committee how many deliverables Cerner is to deliver under this contract and how many emerging requirements have been added since signing the contract?
Right now, Mr. Chairman, we have a new chief acquisition officer and a senior advisor for IT to Secretary McDonough. So they are bringing totally fresh eyes to this, and they are reviewing all requirements, and there are many hundreds, line by line by line, looking for redundancies, looking for potential requirements that may have made sense at an earlier phase, but not so much now. So I will take that for the record and get you the final number where we are.
All right, thank you. Thank you. I'd like to turn to Dr. Fisher. Dr. Fisher, what keeps you up at night? And what do you see as the biggest risk facing us?
Well, from my perspective, sir, I worry about my staff's morale. Obviously, this has been a trying year between COVID and now the Cerner Millennium rollout. They've had to face a lot of change. I'm happy to say that we track separations and departures very closely. I have not seen a bump in monthly departures despite all the challenges that they face every day. So I'm extremely impressed and proud of our staff, and they really do represent the best of VA.
Well, Dr. Fisher, regarding morale, has Man Grant staffs experienced any impact on staff retention since EHRM go live, since the EHR go live in October 2020? Have you measured any turnover rate pre and post go live?
Sir, there's been no departure from the campus out of the ordinary, but there is internal movement. For example, we've had a fair amount of turnover in primary care, but I must say that's a commonplace occurrence even outside of EHRM. It is a very trying area to work in, but we're getting better, and we've enhanced staffing to a significant degree, both to mitigate this transformation and to make sure we can respond to COVID-19 appropriately. So
Well,
I am optimistic for the future, sir.
So you've actually increased staffing. I mean, I was wondering about that recruiting, how recruiting was going in Spokane, and has there been any indication that the transition to Cerner has impacted your ability to recruit new staff? And it would seem the answer would be no, since you've been able to increase staffing.
That is correct, sir. I've added 199 people over the last 29 months between augmenting for Cerner as well as for COVID-19 response. We've had full support by both VHA and my vision in those regards.
Dr. Krupa, how are you ensuring that VHA staff are engaged and committed to the success of the project for future deployment?
Thank you for the question. We are engaging with staff, Frontlines at Man Grant staff. We have Cerner and EHRM staff there frequently, and we're working with them to resolve issues. In addition, our national councils are still ongoing. They're involved in all of the decision-making in terms of the fixes that we're doing for Man Grant staff, as well as future design decisions. And the councils, as you know, are 60% field clinicians from the front lines of VA.
Well, thank you, Dr. Krupa. I've gone slightly over my time. I yield back, Mr. Chairman.
Thank you. Mr. Banks, you are recognized for 5 minutes.
Thank you, Mr. Chairman. Deputy Secretary Clancy, you were the acting head of the VHA when EHRM began. I want to ask you this question first, and then I want to hear from Dr. Fisher. I think now is a good time to review the EHRM's program goals. The most basic goal is to implement a new EHR to support the provision of healthcare. And based on the results in Spokane, Doctor, how are we doing?
I would say we are not doing as well as we'd hoped, but that is not shocking. I'm thrilled by the leadership and frankly, energy and excitement that I've heard about among our colleagues at Spokane, and you just heard that from our director there. But it is frustrating business because in the end, the EHR probably itself, the technological piece is about a third of the solution, right? The rest is changing a whole lot of aspects of your everyday work. So many processes that you used to do on autopilot without thinking, now you have to think about, we have a new system and all that, which is a really fabulous idea, but usually for other people, not for me, right? I mean, it's exhausting. At the same time, I think I'm getting that our colleagues are pleased that we've heard their concerns and they are taking them very, very seriously and running them to ground and trying to get this resolved before we move on.
Dr. Fisher, do you want to add to that?
I do, sir. You know, I reviewed my email and various memos in preparation for this testimony over the last year. And I can say without exception that if our staff had an issue and I elevated that issue, there was immediate response, both from VHA and from OEHRM. And they've been very, very good to accept this feedback, to process the feedback, and to get on our campus, talk with our employees, and try to fix these issues as quickly as they can. And I think the one thing that builds confidence for my employees is to see when they raise a concern, there's an immediate reaction and a productive reaction to those concerns. So I find that extremely reassuring. Obviously, I think most of us appreciate that this was a broadly complex program and performance didn't quite meet expectations. So that's always a challenge for leadership everywhere. But I think the degree—
Doctor, let me ask you really quick. What is your productivity level in primary care now? I understand at one point it was below 50%.
Sir, the last time we talked with senior leaders in primary care, they're roughly at 65% of pre-COVID productivity. They're about where they are about at the same level they were at the height of the pandemic.
Okay, let me move back to Dr. Clancy. I think the Cerner EHR has to perform better than VA's current EHR, the CPRS, to be worthwhile. Some in the DoD have characterized their legacy EHR, Alta, as intolerable. I am not aware of anyone characterizing CPRS that way. Do you agree that the Cerner EHR has to meet a very high bar in terms of performance in VA? And what happens if it doesn't?
So, there are surveys of doctors that say that the VA legacy system is one of the best, which is not surprising. It was built by doctors for doctors, and it was built before many organizations actually did their billing electronically. It is really a whole new world right now, and we need to all of the contemporary adjustments that go with a modern electronic health record, and that's not what Vista was built for. I am confident that we can make practice consistent across the Veterans Health Administration and that the new workflows in the end will be much better for veterans and the clinicians serving them.
All right. Another goal of EHRM is to create a single lifetime health record for service members and veterans.
Yes.
In other words, to eliminate the need to transfer records between DoD and the VA. Have we accomplished that, Doctor, in Spokane?
Not yet. This is our first go live site, but we will be able to do that, which will be very, very exciting. At best, previously, we've had a workaround, which is not bad, but it is definitely a workaround. Ultimately, we think.
Go ahead. I'm sorry.
No, I was just going to say, I think this will also give us a lot of information about the impact of potential exposures on veterans' health. We'll be able to get that directly, which would be really phenomenal in terms of building the science in that area.
Okay, thank you. My time has expired.
Thank you, Mr. Banks. At this time, I'd like to recognize Mr. Brown for any questions you may have.
Mr. Chairman, I don't have any questions at this time. I yield back my time.
Thank you, Mr. Brown. At this time, I will recognize myself for 5 minutes. Dr. Krupa, the term workaround has been used many times while conducting oversight over the course of the last 2+ years. Workarounds were developed to bridge the gap between capability set 1.0 and 2.0 when the full capability set was not ready for the IOC go live. Workarounds were developed during the go live to mitigate unforeseen issues during the go live. And workarounds continue to be utilized to address issues that are just now presenting themselves. To me, the term workaround indicates that the system is not working the way it should or the way staff would like it to work. I am concerned that the normalization of workarounds represents an acceptance that the product is not optimal. Staff are expected to make do, and we are not delivering the best value to our veterans or taxpayers. How many workarounds has VA cataloged? How many workarounds has VA cataloged?
Thank you, sir. I don't know that I can give you an exact number. Workarounds are common in every system. No system meets every need. Some of the mitigation plans that we use as our technology is still evolving were planned and were trained to the staff so that they knew what those what the process was going to be. We are constantly improving. I can tell you that we've already implemented over 350 change requests since go live at Man Grant staff. We've had multiple interface enhancements and improvements since then. So we're constantly working to close those gaps. And we went live with a capability set that met the needs of Man Grant staff. Yes, we're still building out some of the design that is needed for the more complex medical centers, but we did the capabilities that we implemented at Man Grant staff met the levels of complexity and the services that they offer to veterans in Spokane.
Of the workarounds, are they system issues? Are they over-engineering or workflow issues? Is there a majority of one of the three?
I would say that the mitigations that we're having to do often have to do with where VA is different than the commercial system. In the areas of the hospital that are very similar to commercial system, for example, urgent care and inpatient care, it's going very smoothly. The places where VA does care differently are places where we've had to do more adjustments. So for example, in primary care, we have a very integrated system, a lot of referral activity. That is more of a challenge in the Cerner system than in their commercial practices. Things like service connected and special authority. Of course, no other healthcare system in the world has to deal with that designation except for VA. So we've had to make adjustments for that. So I think most of those changes are places where we are different than the commercial practice and we're making adjustments and building that with Cerner to make sure that it flows easily for our staff.
Thank you, Dr. Cooper. I have two more questions. How does VA plan to address these workarounds, and how do you intend to engage with staff to ensure a full accounting for workarounds being developed in the clinical setting?
So that is why we, have been listening to the Man Grant staff, why we've had the Tiger teams, why we've had Cerner and Ehrm and VHA staff on the ground there, watching, timing, really looking at the data that's in the electronic health record itself to see how people are using the system so that we can optimize the use and then translate those lessons learned into our training and change management for future sites.
Thank you, Dr. Krupa. My next question is for Dr. Fisher. We have heard the frontline clinicians at Mans Grant staff that they have grown disillusioned with the incident ticket process, that they do not feel the issues are being addressed and that the tickets are being closed without explanation. Because of this, we're hearing that staff have, to some degree, stopped creating tickets. They are developing their own workarounds and sharing them with their peers outside the VA's incident management system. It seems to me that this means there are issues out there that the OEHRM may not be aware of. Staff has resigned themselves to solving the problems themselves, and these issues are not going to be addressed before the system is rolled out to the future facilities. Dr. Fisher, have you heard similar concerns about staff not creating incident tickets?
Sir, yes, I have. I think it's an exceptional circumstance rather than a routine one. I know that the optimization event in December, when Dr. Krupa and her staff, as well as Cerner associates, visited the facility and received the input about a very complicated ticketing program. And I know they're working hard to improve the transparency of ticketing, as well as sharing the status. If it was closed, why was it closed? When was it closed? I know there's a lot of work being done. With respect to frustration with the ticketing system in general, there are many methods we elevate concerns from staff. I have a morning huddle with my senior leaders every day. I talk with the service chiefs weekly at least. And when I get input about a concern or a struggle or a patient safety risk, I immediately forward that to senior BHA and OEHRM leaders. So I'm comfortable, not happy, but comfortable that those significant issues are being elevated and recognized. And of course, we continue to encourage our staff to not only put in a trouble ticket, but to also put in a patient safety report if they're concerned that patient safety can be impacted.
Thank you, Dr. Fisher. At this time, I'd like to recognize Mr. Rosendale for 5 minutes of questions.
Thank you, Mr. Chair. I'm going to start off with Mr. Short. Mr. Short, can you walk me through how any VA medical center can use the Joint Health Information Exchange, even medical centers that do not have the Cerner EHR? If you want.
Yes, sir. Hear me? Is my mic on?
Yes.
Okay, thank you, sir. Thank you for your question today. When the Joint HIE, Joint Health Information Exchange, was launched for DOD and VA, both of them are using it for the legacy side and the new side. From the legacy side, that is being fed to the Joint Longitudinal Viewer, JLV. That is where people used to go to before to see the HIE data that people were using from the old VA HIE. Now that it has the more robust and more connected Joint HIE, that's still feeding to the same place. Inside of the Vista CPRS screen, they click on a little JLV button, it launches JLV, and they can see all that data together.
Okay. That seems to be fairly simple. Dr. Clancy, this sounds like an incredible bargain. I mean, compared to the $16.1 billion EHR, and a plausible option for VA and DOD to interoperate if all else fails. There still is a system. How much would it cost to replace or modernize the JLV, which is basically our front end portal?
I can get you a number for that for the record, but I want to be clear about one thing. First is that both DOD and VHA will be living in a hybrid world for a while as more and more facilities come online to the Cerner product. The second is that a big reason to have a modern contemporary electronic health record, a commercial system, is that the EHR not only supports clinical care, but it also supports our needs for knowing where and when we need supplies, something that has been very, very challenging, and particularly during the pandemic. And it's an area where healthcare overall struggles quite a bit, getting supply chain issues right, as well as our financial transaction system. So that joint viewer would not be able to impact any of those associated issues. And that is true of any commercial electronic record.
But it still would be for a fraction of the cost, even if we couldn't incorporate that additional information.
Well, that is correct, but it would mean that we would be still struggling with these supply chain issues, which are becoming pretty painful.
Okay. Dr. Matthews, Dr. Krupa, I understand you've been the Man Grandstaff Medical Center and used the Cerner EHR there. Dr. Fisher, obviously you run the place. This question is for all three of you. How will we know if the strategic review is successful and the EHR is sufficiently improved? Basically, what metrics will the review track, and what are the measurements of those metrics today, and where do those metrics need to be? Where are we starting? Where do they need to be? And what exactly are the categories or metrics?
Well, I'll start with that and then I'll pass it to Dr. Matthews. Certainly from a technology standpoint, we are able to track the time that people take in different tasks that they're doing in the EHR. So we can see how people's time is decreasing. So they're getting better. It's taking them less time. They're more efficient. So those are some of the metrics that we're going to track. Obviously, we're going to continue to work to close all of the issues that have been brought forward in the Tiger teams. And obviously, work with the frontline staff to get their reactions and their level of confidence in the system. And I'll pass it to Dr. Matthews as well.
Thanks, Dr. Krupa. I think the one thing I would add to that, those are definitely important metrics that we're looking at. The one piece that I would add would be looking at really an evaluation of user experience, their ease of using the program itself. And we've been discussing within our change management conversations about how best to measure that. There are actually some industry standards on how to measure user experience. And then feedback on training. That was also one of the lessons learned about just really the robustness of training in general and how we might add to that, how the changes, as Dr. Cooper has mentioned, get adapted into the training. So the feedback on the training as another area of user experience would be another metric.
I see my time is up again, Mr. Chair.
Yep. At this time, I'd like to recognize Chairman Takano for any questions he may have.
Thank you, Chairman Mervan. Dr. Clancy, I don't know if you're still here. There you are.
Yes.
You mentioned the inability of the joint legacy viewer, the sticking to a lesser cost option would inhibit the ability for you to have the supply chain management issues resolved. I will attest that when I was getting weekly reports from Dr. Stone about PPE supplies, and we were trying to, we were doing a lot of oversight to make sure that VA wasn't withholding PPE or they weren't hiding PPE. But I understood, is it true that you had to actually manually go and count manually the PPE or supplies or gowns at a particular site, and then that had to be manually put into a spreadsheet, and that was how you're reporting back to people like us in Congress?
That is a very apt description of exactly what was happening. So we are looking forward to having an electronic system that makes that much easier. In addition to everything that you described, we were also calling on network directors who might give people like Dr. Fisher a call to say, you know what, you've got a lot of gowns and that's great, but you have more than a 2-week supply. So we want you to send some to Seattle. And they might tell another facility to send man grant staff other supplies, but that's exactly how it worked.
So when a system is huge, I mean, the largest system that we have in our country, 150 plus medical centers and even more CBOCs, managing the supply chain during the time of pandemic is really critical. Knowing how many masks you have, how many gowns you have, or how many you don't have, and how many days supply you have in one region of the country, which may be under siege with infections. I was kind of surprised you weren't able to jerry build something. I mean, you had to continue to count these things manually. Can you comment on that?
Well, I think we have made some efforts in the past with radio frequency ID tags that for a variety of reasons did not work out, which would be another way not to have to do it manually, right? If every time you opened a box of gowns or received a new box of gowns, you could click on that tag. That did not work out for us. This is a very, very common problem in healthcare, though. And I think accounts for why we also on news accounts almost continuously about PPE across US healthcare.
All right, who can explain to those of us on the committee what capability set 2 is. And I guess as the spring of 2020, the VA's plan was to deploy capability set 1.1 at Man Grant staff in March of 2020, then deploy capability set 2.0. Does that have to do with like the different functions, like the scheduling function?
So I could probably take that, sir. Capability set 2 is adding in capabilities that are needed at a more complex medical center. So 1.1 was what we built for Man Grant staff. 2.0 is additional specialties, things like transplants, things like dialysis, oncology, things that a smaller medical center doesn't do. But obviously, we need that to go to Puget Sound and some of our higher complexity medical centers.
So what is the current timeline for the completion of capability set 2.0?
Capability set 2.0 is most of the vast majority of the design work is completed. Cerner is building that out, and we will have that available for our go live in Puget Sound.
Do you expect that the strategic review will have an impact on that timeline in any way?
No.
Okay. Let's talk about the Cerner scheduling solution, the CSS. On August 2020, VA deployed the Cerner scheduling solution at the Chalmers VA Ambulatory Care Center. Since then, VA has announced they have put the accelerated deployment of CSS on hold. The solution is important to minimizing wait times and improving veterans' access to care. Can you update us on the plan for implementation of the accelerated CSS?
Mr. Chairman, as we discussed at a previous hearing, the CSS plan was a bridge that gave capabilities to the enterprise sooner in the realm of scheduling. As you know, we have a Vision 20 and Vision 10 approach now, especially as a byproduct of the pandemic, and in that we're going to be deploying in 2 regions simultaneously. The CSS plan is not off the table, but it is something that is taking a back seat to obviously the challenges that are presently being undertaken in Man Grant staff. I'll be sitting down with the Deputy Secretary and staff to assess the viability of the CSS approach in moving forward. I don't have a definitive answer, so we'll take that as a lookup as to how we can incorporate it into our subsequent plans.
All right, I appreciate more information about where this stands. I yield back, Mr. Chairman.
Thank you, Chairman Takano. At this time, I'd like to recognize Representative Jim Banks for 5 minutes. If he has no further questions, then I will recognize myself for 5 minutes. Dr. Fisher, a quick follow-up on the question on how many patient safety receipts have been submitted?
At last count, we've had 247 patient safety reports entered into the system of various urgencies.
And Mr. Wyndham, how do you plan to address this lack of faith in the incident management system?
Sir, we have commissioned, matter of fact, Dr. Krupa, I'd ask her to piggyback on this discussion, is that what we've got as you bring a commercial system together with a clearly established legacy VISTA system, you got some translation challenges. Cerner speaks in one language and the VA speaks in another language, and that language barrier is being resolved. I pointed the IOC site as being a place where we're able to start speaking the same language. And I believe much of what's been going on in the incident reporting system has been a translation barrier. And so I commissioned Dr. Krupa, I guess about a month and a half ago now, to stand up an action group to start, developing the decoder rings such that people know that their problems are being resolved. There's nothing worse than calling a help desk or issuing a ticket and then feeling it's not taken the level of importance that you need to do your job. So Dr. Krupa, if I can turn over to you, ma'am, to add to what's going on.
Certainly. So the 2 main issues that we're working on in terms of the ticketing process is assuring that the tickets get to the right place. There's 2 types of tickets. There's the incident tickets, a break fix, and a change request. An incident ticket is usually handled very quickly. Cerner is able to fix those technical issues really within hours to days. change requests have to, be reviewed and decided upon by the National Council, and then, a solution has to be found. And DOD has to also be part of that decision-making. We are in the same instance, they require to be part of that. So those change requests do take a longer time, and we need to make sure that all the people involved in that ticket understand where that ticket is and manage their expectations in terms of how quickly we can turn those around. For things that are true patient safety issues, we expedite those with a bridge line, and those tickets are resolved within 24 to 48 hours. The other change requests are prioritized and then worked through the process that we worked through with Cerner and the DoD. But we're committed to greater transparency and are building a dashboard so that people who put in tickets will be able to see their ticket at every milepost, so that they understand what's happened with their concerns.
Thank you, Dr. Krupa. For Dr. Clancy, we have heard that VHA has expressed concerns about prolonged productivity loss since the go live at Man Grandstaff. While I understand some level of productivity loss is to be expected after a major IT implementation such as this, I understand staff's concerns. Can you tell me the average number of patients that a primary care provider is seeing per day at Man Grandstaff?
I would have to refer that to Dr. Fisher. I would just make the observation, which I learned from Dr. Krupa, that we are not seeing a sharp decline in productivity across all areas. Some areas really have seen a very small drop in their sort of back at normal baseline status. But Dr. Fisher, can you answer that question, which I understand to be a little bit complicated given the fact that we are seeing so many people virtually now?
Yes, ma'am, that's true. We track capacity very closely in our various service areas, and it's highly variable depending if it's something that Cerner typically does in the health record or if it's something unique like in our community living center. With respect to primary care, there are between 6 and 7 patients a day, and that includes virtual and face-to-face care. They work very hard. They're working very hard with OEHRM and Cerner to get some traction on improving that productivity. But if you ask today, we're at between 6 and 7. And so roughly 60 to 65% of baseline productivity prior to COVID.
And if I may follow up, to be clear about the data, when you describe productivity loss, are you comparing current productivity to pre-go live productivity, as in September and October of 2020, or are you comparing it to pre-pandemic productivity, as in late 2019 and early 2020?
Well, we actually look at both cases, but I'm mostly focused on the pre-COVID-19 productivity rather than the height of the pandemic. We look at both, and I think we're probably close to where we were in the height of the pandemic. But my goal is to be where we should be when all things are steady state, business as usual. And for me, that's pre-COVID, sir.
Thank you, Dr. Fisher. At this time, I'd like to allow Representative Rosendale 5 minutes.
Thank you very much, Mr. Chair. Dr. Clancy, we've had some discussions and I appreciate all the information that you've shared with me. I understand that the Columbus Go Live will now happen after the strategic review. I think the real question is how long after? If the countdown to go live starts during the strategic review, it will not make a positive impact on the results in Columbus. And as you well know, and I've shared this with you, I'm concerned about starting something until we have all the kinks worked out, especially as I sit here today and Mr. Chair talks about 240 patient safety events. That gives me grave concern, I will tell you. So again, I want to make sure, do I have your commitment not to start any Columbus Go Live activities until after the strategic review has been completed and shared with this committee?
Yes, you have that commitment.
Okay. Mr. Chair, that was my final question for this panel. Thank you.
At this time, I'd like to represent Chairman Takano with any questions he may have.
I want to associate myself with a question that I was asked by Mr. Rosendale. That was a really great question and a commitment you extracted out of Dr. Clancy. And Dr. Clancy, I just appreciate all of the work that you all have done in the midst of this pandemic. I look forward to working with my Republican colleagues as well as the majority in getting this online. When I want Mr. Rosendale to know, when I first got to Congress in 2013, we heard the disappointing news that they were going to abort any attempt to unify these records. And it was just crushing to hear this and to hear the stories about military service members that really suffered real harm from the lack of interoperability between the two systems. And we cannot continue to operate in that way. Can you just elaborate a little more, Dr. Clancy, on the capacity of an interoperable system in terms of aiding us in toxic exposure research? I mean, I think I heard you allude to that earlier.
You did.
Yeah. Can you expound on that some more, please?
Certainly. Because the goal here is to have a seamless record between a person's experience as an active duty service member and when they become a veteran. So we don't have to go look up or find out what they were exposed to and so on and so forth. Now, it's not going to be easy as turning on a button, right? Because sometimes there are issues that are harder to track, and some people were exposed to potentially toxic substances some years back. But ultimately, I think the Secretary has really emphasized a strong proactive approach to building the science necessary to understand the impact of a variety of exposures on veterans' health. And I do think having a seamless interoperable record will be an important part of that approach moving forward.
All right, but have we dealt with the issue of legacy records? I mean, I understood that the contract did not include DOD, that this contract with Cerner didn't include the legacy records from DOD. Are we somehow is that true? I mean, are we still gonna be able to go back and include them?
John, is that correct?
The migration of data in DOD, and I don't want to speak for DOD, sir, has been less substantial than what we moved. I like to refer to Mr. John Short because he lives the data migration. So John, if you give the chairman the update on what data has moved within VA and what data is either anticipated to move or has moved in DOD, would be appreciated. Over.
Chairman DeCano, thank you for the question. Mr. Wyndham, thank you. So what is all the data in VA from Vista from 1981, the first lab record recorded, all of that's been migrated to Cerner and has been cleaned up and made semantically interoperable with the new Cerner data, as well as all the new Cerner data coming from DOD. DOD has moved about 3 years of data from legacy data into Cerner also, and they were looking at us and what VA has done to move our records. They haven't made the decision to move all their data yet. They've been talking about it for the last year or two, but again, don't want to speak too much on DOD's side, but the Cerner contract allows for when DOD moves the rest of that data into Cerner, it'll all be moved into a single longitudinal record called the Long Record Service, where all new EHR data, all legacy DOD and VA data, and all community care data will be semantically interoperable. And so when the veteran goes into the portal and presses blue button to get a copy of the record to give to a clinician or keep for themselves, they'll have their full, complete long record.
Well, thank you for that. I mean, I wish I could linger longer, but I've got to get to another meeting. But I want to emphasize how critical it is that we realize this intention, because it's not just a veteran, it's also our researchers and our scientists who've got to be able to analyze all this data so that we can truly understand the effects of toxic exposure. It has a big, as you know, there's a lot of consequences on how our disability ratings are going to work. So I think it's high time we were able to utilize technology to be able to enable our scientists to be able to to make these determinations. I've got to yield back and I've got to go, but thank you so much. This has been a very informative update and a very informative oversight hearing. And Chairman Moran, thank you so much. Mervan, thank you so much for your work, and thank you to all the witnesses.
Thank you, Chairman Takano. With there being no further questions, the first panel is excused. I want to thank you for your participation today. We will immediately begin the second panel. I thank all of you for your time and commitment to the veterans and to healthcare for our veterans and for your service. I appreciate it very much as the chairman of this subcommittee. Our second panel, we also have with us Mr. Brian Sondiger, the General Manager of Cerner Government Services. Mr. Sondiger is accompanied by Mr. Avi Vaswani, Vice President of Cerner Government Services, and Ms. Melissa Soloto, Vice President and Chief Nursing Officer of Cerner Government Services. Mr. Sondiger, you are recognized for 5 minutes.
Thank you, Chairman Mervan, Ranking Member Rosendale, and distinguished members of the committee. My name is Brian Sondiger, Senior Vice President and General Manager of Cerner Government Services. I am joined today by Avi Vaswani, Vice President and Program Leader, and Melissa Solito, Vice President and our Chief Nursing Officer. I'm grateful for the opportunity to participate in today's hearing. I want to thank each of you for your continued engagement and support of VA's historic electronic health record modernization program. Cerner is honored to partner with the VA to deliver seamless care for millions of our nation's veterans. We owe it to them to get this right. It remains Cerner's position that based on commercial standards and lessons learned from the DoD and clients around the world, VA is well positioned to continue deploying the new system. Having said that, I acknowledge that there are real challenges that deserve our attention and our commitment to resolve. That is why Cerner strongly supports Secretary McDonough's decision to conduct a strategic review. I believe it's important to take a moment to acknowledge the historic milestones achieved so far. Thanks to the commitment from VA's leadership, VA's frontline staff, Ehrm partners, veterans service organizations, and our industry and small business partners, for the first time in history, 3 separate federal agencies are now operating in a single common system across 20 DoD commands, 4 U.S. Coast Guard sites, and the Manned Grandstaff VA Medical Center. To get here, we hosted 8 national clinical design workshops with frontline staff and leadership across VHA, OINT, DoD practitioners, and various industry leaders, during which the VA developed over 1,200 national clinical workflows, and of those, 919 are now live at Manned Grandstaff. We launched a new joint health information exchange with DoD, VA, and the U.S. Coast Guard, making it easier to share and receive patient information with their community care partners. We successfully deployed the centralized scheduling solution for the VA Central Ohio Health System, and we completed one of the most comprehensive health data migrations ever. The new system is being used and it is working. In my 20 years at Cerner, I've had the privilege of working with multiple health systems and care facilities around the world as they successfully deployed our solutions. As with any healthcare IT transformation, we knew there would be challenges. Sometimes what you design on paper is over-engineered and it doesn't fit local workflows, and we need to modify those. That is why we plan to deploy at select initial operating capability sites to quickly identify challenges and resolve them. We are using a combination of data, insights, and end user feedback to inform VA decisions. Since go live in October, 74% of veterans are seen within 15 minutes of scheduled clinic appointment times. Average time spent in the EMR per encounter is down 32%. And over 190 opioid prescriptions have been modified based on Cerner EHR alerts, resulting in alternative treatments for those at higher risk of opioid use disorders. Most importantly, veterans and service members in the Pacific Northwest are benefiting from seamless care between VA and DoD. Veterans and service members have received COVID-19 vaccine at either a VA or DoD facility, and then had a subsequent encounter for their second dose at the other agency. Prescriptions are being written by providers at one agency and filled by pharmacists at another. Alerts are being generated to notify clinicians at one agency that orders are being placed conflict with or impacted by orders placed by a clinician at another facility, improving patient safety. On a recent trip to Man Grandstaff, I had the opportunity to thank them in person and listen to their direct feedback. The staff embraced the opportunity to go first. They have been incredible partners as they have navigated everything from a global pandemic, severe storms, power outages, and even wildfires. While in site, I saw firsthand the impact of advancements we are making to the systems and the remaining challenges we need to resolve. Together, we are building a more connected world where our veterans and service members can thrive. This work is important, and Cerner is fully committed to supporting the VA in their efforts. With your ongoing support, we will succeed. Thank you, and I look forward to your questions.
Thank you, Dr. Sondager, or Mr. Sondager. I appreciate all that you have done. At this time, I'm going to recognize myself for 5 minutes of questions. Mrs. Sondager, what is Cerner's view of the issues that have been raised at Man Grandstaff by VA and frontline staff?
Thank you, sir, for the question. We have learned a lot in the initial operating site capability deployment as the VA had talked about. And we have learned and implemented a number of changes already to improve on those issues. There's been, as Dr. Krupa said, over 350 configuration changes just in the few months since go live that have really improved the experience for both end users and for veterans. And that learning will be applied to future sites as we move forward. And I think that has been really important in accomplishing what we needed to accomplish in the first initial site. I would like to just use one example, sir, of that. As discussed in the previous panel, there was a large amount of data that was migrated, a historic amount of data migrated for the VA on this program. As such, there was a lot of medication information that was brought across. That took a lot of time for clinicians to reconcile that information. Since the go live, we've been able to allow some filters and additional technologies put on top of that to ease that burden and significantly reduce the time that clinicians take to reconcile medication information while improving patient safety for veterans. That's just one example of many that have helped us improve with the lessons learned immediately following the go live. I'm sorry, sir, but I believe we lost your mute there.
Has Cerner produced a written response to Dr. Stone's findings from his January trip or any other reports regarding Go Live or the state of the EHRM program in general?
So we've been working directly with the VA to support them in their responses to those queries, as well as with the teams on site. So we've been providing data to them, but no, sir, we haven't been asked to provide a direct written response to that.
How do you expect the issues at Man Grandstaff to impact the overall schedule of the EHRM program?
Well, I think, sir, actually the pandemic probably had a larger impact on the overall schedule because both at a national workshop, getting people together to make the decisions necessary for some of the advanced workflows was impacted by the pandemic. I think the team and the VA have done an amazing job of navigating through that to minimize impact to the overall schedule for the 10 years. And I think it's too early to say whether there'll be an ongoing impact, but I'm very optimistic that we will have the ability to deploy on schedule over the 10 years.
On the first panel, I asked the VA about the widespread use of workarounds at Man Grandstaff. I would like to get Cerner's perspective on this issue. It seems to me that a reliance on workarounds indicates that either Millennium isn't meeting expectations or that the system isn't conducive to VA's clinical workflows. What is Cerner's perspective about the widespread use of workarounds at Man Grandstaff?
I think one of the things to recognize in the terminology, as Mr. Wyndham alluded to, is that often a change in workflow for some can be perceived as a workaround when it is in fact just a change in workflow. There are other areas where a workflow is different and does require a different set of steps that can be perceived as a workaround. And a lot of that is really educating staff and educating the teams on that and being able to understand what is really the key metric for success. And we are constantly seeking, clarity on what are those success measures so we can agree on those together. And when we look at time in EMR or time in a workflow, we think that that's a great success measure, as Dr. Krupa had talked about, as a way to measure not just the terminology, but what is the actual effect on the clinician and how effective are they in being able to quickly do their jobs. And that's what we really focus on, both in the commercial setting and in partnership with the VA, is making sure we're making the time in the EMR as small as possible so that clinicians can focus on spending time with their patients delivering care for veterans.
Thank you, Mr. Sondagger. At this time, I would like to recognize Congressman Rosendale for 5 minutes.
Thank you, Mr. Chair. Mr. Sondagger, while you're in the hot seat, I understand that Cerner recommends that its clients implement the standard EHR as much as possible and resist customization. Why is that? And isn't that like trying to drive a round peg in a square hole?
Well, sir, what we've found over decades of implementing EMRs around the world is oftentimes, although clinicians and health systems have a way of doing things, when they look at the data and standardization of care, the outcomes for patients are better. And so whether it's within an individual health system or across the country or across the world, we have, in a modern EMR, we have so much data available to clinicians. And as I alluded to in my opening statement with the national workshops, bring in industry leaders, bring in all of that data for the VA to look at their workflows and really go to what is a standard workflow, whether that be recovery for a knee surgery or for just an outpatient visit. Those standard workflows, from an industry perspective, bring in that best practice. And the VA has been a leader in driving industry best practice and really has done a great job in their national workflows and workshops and looking at the data to try and drive to those standardized decisions. As said earlier, there absolutely are areas where divergence from a workflow is necessary from the standard because the patient is different. The VA, as Dr. Krupa said, has different patients. They have a higher level of prosthetics than commercial clients. They have a higher level of folks that have had toxicity exposures and things like that. So those are where custom workflows make a lot of sense.
Sure. And so for specific procedures, I get it that it would be a little bit to have the ability to standardize some of that, but some aspects of the VA are unique, as you just point out. Other hospital systems don't have necessarily nursing homes. Other hospital systems don't collect copays based on disability ratings. There are many other examples. The VA requires some customization, but customization apparently can degrade the EHR's performance. How do you reconcile these competing interests?
So one of the other great things about a modern EMR is that we have literally thousands of performance data elements that we measure across the system. We measure things called average transaction response time. So every time you click in the EMR, the system measures how fast the system responds. We literally track mouse miles, so how far you have to move across the screen in order to click on different things to optimize design. So we can see, within the EMR, if a customized workflow is resulting in system performance, we're able to work in partnership with our clients to improve that performance. Maybe there's a lot of data that's being brought into that custom workflow, and we can surface the data initially that is most critical for that decision while the rest of that data is retrieved. That type of staging of the data retrieval can actually optimize the system performance and make the user and the clinician's experience better. So all of those data elements tracking in the system in partnership with the VA helps make sure that they have the best performing system. And that's why we've gotten great feedback from system performance from the VA at Man Grandstaff. You know, their login times are 3 seconds. That took a lot longer in their previous systems. People would often log in, go out, get a cup of coffee, come back, and then start their work in the system. They don't have to do that anymore. They used to have to log into multiple systems. Now they log into one. All of those things are helpful for the clinicians and the end users, but there are absolutely areas in those custom workflows where we see opportunities to continue to improve, and we'll continuously do that from now until the end of time. We'll never stop looking at ways to improve the performance of the system.
So I want to get to the core competency of the firm right now and ask you a question. Cerner has clearly taken on more and more work since the contract was signed. And at one point, you even bought a company for its expertise with older VA systems. Is Cerner being tasked outside of its core competencies?
No, sir, we don't believe that. And frankly, when approached about taking on work that isn't our core competency, we have been very transparent to say that that's not something that we could successfully do on your behalf, you know, and have pointed to partners or other people that might be able to do that work. Where we have taken on work is where it was in the critical path for successful deployment, and where we were already doing work as well. So to your point, sir, on the VA legacy systems, we took on additional interface work where we were doing the Cerner side of the interface anyways. So being able to do the other side and accelerate that to help VA get through those challenges was something that we felt we could do successfully. And Man Grandstaff, with a number of interfaces we brought live with 0 technical issues and only 1 ticket with that interface. All of those interfaces we took on, I think is good proof point that we were able to take on that work successfully on behalf of the VA and the team.
That's my time, Mr. Chair.
Thank you. At this time, the chair would like to recognize Ms. McMorris Rogers.
Thank you, Chairman Mervin and Ranking Member Rosendale. I really appreciate you agreeing to allow me to join today's hearing. I have the honor of representing Man Grandstaff, and I think we all agree that achieving top-notch veteran care is the #1 priority in everything that we do. And I am committed to doing everything that I can to make sure that this transition to the electronic health record is successful. I'm very excited about what it could mean. It's been a long time goal. And so I appreciate all the work that's been done. I appreciate all of you on the committee. I know many of you have traveled to Spokane, and everyone is committed to assuring that we have a successful rollout and modernization of the electronic health record. I want to thank Dr. Fisher, who is the director. He was on here just a little bit ago, but boy, he's been on the front lines. And as the director of Man Grandstaff, and just doing all of this in the midst of a pandemic is not easy. And I also want to thank Cerner, who has been very engaged with my office in sharing information and answering questions about the situation on the ground. We all share the goal of making sure that this electronic health record modernization serves our veterans and serves them well. So I had a few questions that I wanted to be able to ask today. I'll start with Mr. Sandegger. We are getting specific complaints in my office about the electronic health record at Man Grandstaff. And one of the most common complaints right now is about the prescriptions and the patient portal. And I understand that any new patient portal is a big adjustment, but anything that impedes people from getting their medication and getting their accurate medication is dangerous. And what I'm hearing is that the wait times for the call center, which is the workaround for the veterans who are struggling to refill prescriptions in the patient portal, are too long. As another workaround, the medical center employees are sending veterans to urgent care to get a 30-day refill of prescriptions. So I'd like to ask, just what is Cerner doing now, and what does Cerner plan to do moving forward to solve these problems with the patient portal so that veterans get the prescriptions that they need and when they need them?
Thank you, ma'am, for the question. I appreciate it. And thank you for your and your staff's support in making sure that we do get feedback on the ground and that we can quickly address that. To start with the prescription feedback, As alluded to earlier with the medication migration, making sure that clinicians were able to get through that medication reconciliation quickly and identify the meds that need to be renewed, shortening that workflow, improved accuracy for the providers and their prescriptions. Secondly, we also held a number of what we call favorite spares, which is just working with providers on here are the medications that you order for veterans most frequently, and helping educate them on the fastest way to go do that so that they can reduce the time it takes them to order. And we've seen a significant drop in the time to order meds from the initial go live until now. I personally met with the pharmacy director along with, all of a lot of the providers on the ground when I was out there. And those improvements right off the bat are immediately seeing results. The number of error in prescriptions has gone way down. The pharmacy's been tracking that. In addition, ma'am, to your question on the wait times, we do track wait times both for clinical staff calling in to our clinical help desk, as well as for veterans calling into what is on the commercial side called our consumer help desk.
Okay,
And-
very good.
and we-
I just want to try to get in another question here too. Because the Cerner system, we're getting complaints that it's starting to freeze up more often. And I know, I understand that these are very large patient files and the history being loaded. But the VA has spent millions of dollars to replace computers and upgrade the infrastructure per Cerner's specifications. So I just wanted to ask, are there further upgrades, whether hardware or software adjustments needed?
We will continuously upgrade the system. We have upgrades scheduled, every 6 to 12 months. We're constantly taking new code to make sure that the system's always modern. And we'll absolutely look at any of those transaction response times. If there's any freezing in any workflow, we're constantly working to optimize that. Yes, ma'am.
Okay. Thanks again. Good to be with all of you. I yield back.
Thank you.
At this time, I am going to take 5 more minutes for questions. One of my questions that I have is, what does the program management status reporting across all stakeholders reflect? The schedule, the budget, the clinical quality, and the patient safety?
Thank you, sir, for the question. When we look at all of the program reporting deliverables that we deliver to the program office as a part of the implementation of these systems, there are literally thousands of deliverables that we deliver as a part of this project. And I would like to have Avi speak here in a second as the leader of our deployment teams there on some examples of those deliverables. But we do report on everything from the build status of every individual site or function. We report on the workflows. We report on things like that. So happy to share any additional information that's helpful there. But Avi, maybe you could jump in to talk a little bit about some of the other things that the team delivers as a part of the program management function.
Thank you, Brian. Yes, as part of the program management deliverables, one of the items we do deliver is an integrated master schedule. The integrated master schedule provides an ongoing view of the program deployment schedule over the contracted period of performance. That IMS is reviewed through management reviews and with VA in partnership so that we are monitoring and tracking and controlling all of our schedule. In addition to the schedule, we also are looking at monitoring and managing our scope. To that end, we do provide a requirements management deliverable and function. Our program management office provides several different disciplines of support to ensure that we maintain the integrity of the cost, the schedule, and the scope. Those items and those service lines include things like governance, include things like requirements management, schedule management, and similar other activities.
And then my final and follow-up question is, how is Cerner addressing the voice of the customer, the veteran?
Thank you, sir, for that question. For us at Cerner and for all of our team here, This voice of the customer, the veteran, and their family members is really personally why we all joined this mission. And so we have spent a lot of time working with veteran service organizations, working with members of Congress and with the VA to make sure that all of those voices are heard. The voice of the veteran is really important to us. After all, it's why we're all here. And so we leverage all of those tools along with, feedback directly from, our help desk as they call in to make sure that we're listening to them. We hold advisory panels with VSOs to listen to their feedback as well as educate on, the benefits of the system and making sure that those are what the veterans need in partnership with the VA. So those are just a few of the ways that we try to make sure we're getting direct feedback from veterans in the community on the care and what their needs are.
Thank you, sir. With that, I yield back my time. At this time, I would like to ask if any of my colleagues would care to add any closing remarks. Well, I want to thank you. I want to thank you very much for your time and attention, and I appreciate the closing statement that joining this mission is about making veterans quality health care a #1 priority and making sure that we have this transition to increase their quality of care. With that, this subcommittee will continue to oversee these modernization efforts, and we expect VA to continue to keep us abreast of the progress and changes as they happen. This is a major investment of taxpayer dollars into a program that promises to benefit veterans, to support the clinicians that endeavor to provide excellent care, as well as the VA staff who work hard to ensure the VA healthcare system operates as effectively and efficiently as possible. In this effort, no half measure can be accepted, and I know we all hope it is nothing but successful. And I thank you very much for your time this afternoon.
Thank you. Appreciate it.
At this time, we are adjourned.